Thanks for joining us this week on Email Geeks at Home Drinking Coffee. Join your hosts Chris Marriott and Paul Schreiner each week as they talk email marketing, life, purpose, faith, but mainly email marketing. If you're looking for some normalcy in these crazy times, you've come to the right place.
Welcome back to season 4 of Email Geeks at Home Drinking Coffee. My name is Paul Schreiner. With me, as always, is the venerable Chris Marriott.
Chris Marriott. Great to be here, Paul. Great to be kicking off season 4. Who thought back in April, in our humble beginnings, there'd be a season 4, but here we are. We've booked several episodes already, and we're going to kick it off with a great one today, one that we're really excited about. We have a guest we're really excited about featuring today. And this new season is theme, because we like to have themes, is getting a lot done.
That's right.
And
that's what we do.
And all of our guests this year will be getting a lot done. And whether it's getting a lot done at the office, getting a lot done in their personal life, that's the theme, and we're sticking by it, and we're gonna force fit it to any guests we have.
That's the way. That's why we're committed to going. I don't care if it's a march off a cliff. We're committed to doing it. You know what I mean?
Yes. And so in a sense, you could even say that, Paul, you and I are getting a lot done.
That's true, Chris. We are getting a lot done. And I think that brings us to a really nice transition into our sponsors, right? We're able to do this show. We're able to trend on the YouTubes and all of the podcast channels because of Audience Point, because of Email Connect. And at an Audience Point, we have, today's show, absolutely fantastic guest. We talk a lot about data and the importance of data, there's conclusions you can only reach through aggregation. And that's been one of those things we've been doing at Audience Point through our new product that we're launching called ListFit. But again, data, the better data you have, the better conclusions you can reach. And that's one of those things that we have spent the majority of our company's existence focusing on getting the right data. And so we're super excited about that and super excited to share. Chris, would you tell us a little bit about the good folks at Email Connect?
Well, and I mean, speaking of data, again, the only way you can evaluate one platform against another is find a way to compare them head to head. And we use data, we use self-reported data, we use scorecards, and as a way to enable our clients to actually see distinct differences in the RFP process so that when they reach the end of it, they know they've made a sound decision. And then we save a ton of money because nobody knows how to get those ESPs down in pricing better than us, because we see more pricing in 1 year than most people see in their career. So Email Connect for all your RFP needs, and Audience Point for all your data hygiene needs.
Look at that pitch, man. Nice job. Well, with that, Chris, I think let's jump into the show.
All right, and we'll see y'all in the post show again.
We sure will. Welcome back to Email Geeks at Home Drinking Coffee. I guess this is technically season 4.
Kickoff.
We have a fantastic guest. Chris, will you introduce him?
Yes, as you can see, we have a guest, and we're opening season 4. Joining us today is my good friend and former boss, Tim Souther. Tim has spent his career applying data to help companies and brands achieve the best possible marketing and business outcomes. He's previously been managing director of JP Morgan Chase. As my boss, he was chief marketing strategy officer for Axiom. He's been the senior vice president of Metavante, president of Protagna Worldwide. And if that's not enough, he's been named exec rank top CMO Club President Circle Award winner, and one of the Nifty 50 in technology. And all that's great. But today we're going to be talking to Tim about his current role, where he's senior vice president, general manager, data solutions at Change Healthcare. And here he's responsible for the overall management direction and leadership to the data solutions business, including his focus on inspiring better healthcare through the effective and responsible use of data and analytics. And I see, Tim, you know I'm reading from my script. I can see that right smile. But there's too much to remember. There's way too much to remember. But now I'm going to go off script and say, we asked Tim to come on to kick off season 4. Those of you who have been with us since the beginning know that we founded this podcaster began it in response to the pandemic and in response to, and our very early episodes were focused on the impact of the pandemic on the email marketing community, hence the name Email Marketing Geeks. And we felt that as we got rounded the corner and started season 4, we really wanted to return, make that topic the pandemic and what the country and what companies are doing to respond to the pandemic. We wanted to put that front and center. And really, there's no better guest that we could have, I think, to do that than Tim and the work that we've seen that Paul and I have seen that they're doing at Change Healthcare. So we asked Tim to come on today and talk about that. Obviously, there's a lot of data involved and in that, which is why Tim's leading that effort. But again, I think it's an opportunity for all of us to hear how, in a world where all we hear are more lockdowns, more cases, that there is progress. And lots of the time it's happening behind the scenes. Right. And it's happening where it's not making it to the front page of the newspaper. It's not making it on the nightly news shows, but it's happening. It's real, and it's extraordinarily encouraging. And again, so we wanted to bring Tim back, or wanted to bring Tim today to talk about that. So Tim, I will now take a breath and say, welcome to the podcast.
Welcome aboard.
Well, thank you, Chris and Paul. It's a pleasure to be with you this morning. And Chris, it's been far too long since we've been enjoying live music together, and I hope at some point soon we can remedy that. So Change Healthcare. Change Healthcare is one of the largest healthcare IT companies in America. It's publicly traded. It's $3 billion plus in revenue, 15,000 employees, and it's probably the most interconnected technology company in healthcare. We sit in the middle between virtually every hospital, every doctor, every pharmacy, every lab, and health insurers. And the reason why we're there is it's very difficult for doctors and hospitals to get paid. Each health insurer has different plans, and if you don't submit a claim, which is a bill, in the format that the health insurer approves, then it gets denied, and everyone's unhappy about that. So these networks, and Change Healthcare is the largest independent network, were formed to solve that problem. And every year we see more than $2 trillion notional spend in healthcare, which the country spends a little more than $3.5 trillion. So we see most of the healthcare spend in this country. So when the pandemic was declared in the first quarter of this year, we began isolating COVID encounters. And by an encounter, I mean a test, a positive diagnosis, a inpatient admission, and discharge. And we know a lot about these. We know who the people are. We know about their previous conditions. We know when they are given drugs. We know whether that leads to a longer hospital stay or a shorter hospital stay. We know whether that leads to a successful discharge or, sadly, mortality. And what we've been doing for most of the year is working with academic medical centers across the country. So an academic medical center is a medical school that's associated with the top universities in the United States. And we just made a really simple call on that. I mean, it said, if you want to go fast, you go alone. If you want to go far, you go together. And while we had all the data at our disposal and we're quite capable of digging in and doing research, we thought it better, to partner with universities all across the country to study, virtually every dimension of the pandemic. So what it looks like, how it's progressing, whether or not, pre-existing conditions are more susceptible or not, whether certain drugs or therapies actually work, whether certain states or communities are doing better than others. The data doesn't lie, and we get to see it updated every single day. So we got a lot going on here at Change Healthcare.
Well, we have a lot to talk about this morning. I'm pretty excited. Before we jump into that, because I know we do. I mean, everything you said there, I was like, we're going to jump on that. We're going to jump on that. We're going to jump on that. But before we start, we have a tradition where we talk about what we're drinking. And Chris usually
omits one ingredient in his coffee for the rest of us, which is why he's so talkative in the mornings.
I omit one ingredient. What is that? What is that ingredient? Love?
Yeah, Chris, that's what I was getting at.
Well, I'll start with that tip off. I'm back at home, so I have. Well, you can't see the mug; the light's too much. But I have my traditional mug, and I have my traditional can.
Oh,
Santo Domingo.
Look at that. Oh yeah, sure.
Now, Paul, where's this coffee from?
It's from the Dominican Republic, Chris.
Ah, yes. You know,
there's an island with Haiti, in fact.
As the weather gets colder and the snow falls on the ground, we all dream of tropical vacations, past and present, and future, I should say, past and future. You're really just going to have to focus on future, though, right? Because you never have been to the Dominican Republic.
No, I have been. I have been. Did you know that? I've been once.
Oh, but you weren't last year when you had your all expense.
That's correct. Yeah, the all expense paid trip that we had, we did not go on. That my mother-in-law was flying out to watch our 5 kids for. Yes, Chris, that vacation to Dominican, we didn't get to go.
I'm sorry to bring it up again. I apologize. It's an accident. So Tim, what are you imbibing this morning?
Well, I have nothing as fancy as the Dominican Republic, but I do have coffee from Jewel Osco, as you know, here in Chicago, and it is Starbucks. Starbucks freshly ground this morning.
Nice. Do you like the blonde, or what's the pike? What's your poison there?
French roast.
Okay, very very good.
And Paul?
I'm drinking the Verve this morning. Is the producer of the coffee. The name of it is called Sermon. I was feeling a little bit snarky when I was at the market and picked it up.
It's called Sermon, so you picked it up on the mount?
On Signal Mountain, yes. Yeah,
Sermon on the Mount.
There it is.
You see what I did there?
I mean, yes, I did.
Not impressed. All right, back to the real stuff.
Yeah, to the meat of it. Tim, great to have you aboard. I think I'd love to dig in on some of the stuff that you brought up around COVID, how things work. I do think there's a lot of interest there. I'd also like to maybe set the table a little bit more with the tension between marketing and data security, especially when you're dealing with medical, because that's even more sensitive. I know there's things that you can do to sanitize your data in terms of anonymization, pseudo-anonymization, separation of responsibilities, all of those things. But I just love to start with that tension, because it's this weird thing, because data privacy is protecting our own medical data and keeping us safe. But when we put too big of a silo over that, we lose the ability to make some of these bigger analyses. Love to just have you talk a little bit about that, and then we can kind of dig more into the COVID.
Yeah, that's a great question, Paul. Privacy, of course, is a factor that we all have to deal with, no matter what industry we're in. And there's a very large debate in this country right now about the need for a national privacy law. And I've been to Capitol Hill on 3 occasions in the last 2 years, talking with congressional staff about what ought to be in that. And of course, the states are active with that as well. California has CCPA that went live. The second version's on the ballot next week, and because it's California, they have a third one, ready right behind that.
Because why not?
Why not? In healthcare, though, it is an industry that already has a national privacy law, and that's called HIPAA, and that's been in place since the late 90s. And in contrast to other industries, it takes, I think, a very rigorous approach to privacy. So in contrast to example for advertising, where you can declare your data anonymized and get on with your day, you can't do that in healthcare.
It is anonymized.
Yeah. Yes. In healthcare, you have 2 methods. You have a safe harbor method, and the safe harbor method is you have to eliminate 18 attributes about people, and they are enumerated in the law. Or what we do is we do what's called the expert opinion method, and the expert opinion method is a statistical test. And there is so they go through and they actually take your data in its combinations, they run math on it, and it either passes the tolerance or it doesn't. And this is a really effective method for ensuring that data stays de-identified. There's plenty of news about healthcare data getting exposed, but none of those have ever been in a case where the data has been de-identified and certified according to HIPAA. And, that's important because of the reason that, underpinned your question. Yes, our individual data needs to be protected, and HIPAA provides that solid foundation. But there's some things that can only be done when we aggregate data. Mm-hmm. So if you want to determine whether or not a particular drug or therapy is effective, it's interesting that it works for Paul or Tim or Chris, but it only becomes really interesting when it works for a lot of people, right? So that requires, aggregating it together. And the same thing is true for research. I mean, our bodies are all very, very complex, and having the ability to appropriately do research across a diverse set of people, that's only possible if you get a lot of people involved. So in healthcare in particular, there is, the tension that you described, I'd frame that as a trade-off. Yeah. I mean, yes, we want to make sure that we protect individual privacy, but we don't want to do it to the degree that it impedes research and safety and outcomes, because that's going to affect everybody. And that's it's really, the balance that healthcare has to demonstrate. And, the HIPAA framework does a great job of doing that.
Good. Got it. And good answer. I'd love to launch in a little bit more on what you're seeing in COVID, because I know that there's a lot of interest and I mean, so much. I mean, you brought up sort of data integrity, right? Like the only way we can sort of arrive at these truths is through reliable data. And so certainly, is your data reliable? Let's assume that it is, because I think part of the reason I bring that up is there's so many forces and tensions coming at us. I mean, the number of times I've heard the word fake news in the last year, man, I'm just done, right? And we're not talking about one political agenda, it's everyone's, right? And so it's all swirling. And so, the importance of reliable data underneath, that's what you've been collecting, that's what you've been working with, and you can arrive at things that sort of spin free, right? At least that's the goal.
Yeah, definitely. So what's the provenance of our data? Well, it starts with what a doctor says. Yeah. So, for example, in the COVID scenario, they will enumerate the test, and there are specific types of tests, and this data is all standardized. So there are particular codes that every doctor, every health insurer uses to identify care rendered and diagnosis. So the data that we have at our disposal is information entered by a medical professional, and it contains their diagnosis. So do you have COVID or not? Do you have presence of the antibodies in your body? So did you have COVID and are recovered from it? What test was performed? And to further add to the fidelity of the data, it isn't like any doctor can just put in what they want. If they did that, what's going to happen on the backside? The health insurers are going to say, how about no? So there is a really good level of fidelity because there's money involved, and you have licensed clinicians that are involved on both sides of the equation.
And there's control. I mean, that's the whole idea.
One of my most famous sayings, Tim, I'm sure you remember hearing me say this many times when we worked together at Axiom, was data that isn't actionable is merely overhead. So my question would be, obviously there is a lot of data to be collected. So my question is how is it being put to use? Who is leveraging this data? And for what purpose? How are you making it actionable at this point?
Yeah, so for us, we're the daily healthcare pulse of America. Every day we see 10 million plus or minus care events that are coming into our system. And every night where we have rights to de-identify it, which is to strip out the personal health information, we do that. Yep. And then the next morning, it is made available to licensees. So many of those licensees now are these academic medical researchers. So if you have, if you're a medical researcher at a leading university and you want to study the impact of diabetes and oncology in a time of pandemic, so are patients with those conditions more susceptible? Okay, now you get to see every day, you know, your data gets updated and you can see the changes in trends. Oh, you want to understand whether or not people are scared to go to the doctor? We get to see that too, because we see not just people who are diagnosed with COVID, but we get to see the balance of those diabetes and cancer patients. Oh, you want to see whether or not a particular therapy is effective in dealing with it? Every day we get to see that. We get to see whether or not those folks are, you know, put into, you know, an inpatient, so they're hospitalized, and we see when they leave. So we have this rich petri dish of up-to-date healthcare information that the smartest medical minds in America can look and you know, profile the disease, see how it's progressing, see what therapies work, and they can break it down by different patient cohorts, different geographies, different therapies, and that's only possible because of the massive data that we have at our disposal.
Seriously. Right. Nerd Paul's super stoked. Nerd Paul's like, what's the stack? Nerd Paul's like, how do I play with that data? I mean, I get, if I'm a researcher in an institution, I mean, there's the ability to sort of do a quick sort of acid test. Does this pass water, right? Let me just run, I have a theory, let me run it against everyone in the world, or, you know, the cases that your care cases.
In the US, yeah.
Yeah, cases. And you're like, oh, wow, 92% say true. So now I've got evidence that says, let me back this into an actual study or research or whatever. I mean, that's, to your point earlier, there are conclusions you can only reach through aggregate data.
That's right. So I'll give you a couple examples. So in healthcare, there is clinical research and there's observational research. So right now, our country has several drugs that are in clinical trials, and that is a double-blind scenario. So patient doesn't know, doctor doesn't know whether or not they are receiving a placebo or the actual drug. And if you look at the population of people that are going through that, there are tens of thousands of people. And, you know, a lot of clinical trials are not normalized for the underlying population. Most of it is white males, you know, like us. So if you're female or you have different ethnicity or, you know, right, different circumstances associated with you, the drug will get passed. But whether it actually works with these, you know, different types of population, nobody really knows. And that's where observational research comes in.
Right. Right.
So in contrast to a clinical trial that might have tens of thousands, we see everybody. So if, you know, if you, after a drug is approved, you want to go and see whether or not a particular ethnicity is affected or a chronic condition of some sort, or it affects older people, younger people, men versus women, all of that, you can go do that with observational research. And that is a lot of what we do right now.
Well, and our daughter is Ethiopian, and when we were living in Port Townsend, Washington, a surgeon friend of mine found an article it was observational research, and it showed the mortality associated with Ethiopians taking codeine-based anything is astronomical. Don't let your daughter have codeine anything. And the only way that shows up is through observational data, right? And
that's right.
You know,
that's exactly right.
I mean, that's fascinating when you think about it, because as you were pointing out, Tim, these drug trials, these double-blind drug trials, are still you know, they are people who self-select to be in it, and so you're left with whoever self-selects to be in it. And as you said, it tends to be, for reasons we don't, you know, that we don't need to get into today, it tends to be guys like us, white males like us. And so what those tests then you come out with is it didn't kill them and it seemed to make them better. But as you said, that's to one group, and until you get it, so now we know it's probably not going to kill anybody. So let's get it out, try it out, and follow it. And only you can do that to say, okay, well, it worked really well in white men. It works almost as well in women. I mean, that data seems to be sort of gold. And I mean, that was happening pre-COVID, I'm sure.
Yeah.
Oh, for sure. Yeah, and both of those are to be valid. I know we're kind of reining a bit on the clinical trial process, but the clinical trial process, is underpinned by very solid statistics.
Right.
So the phase 2 trial is, where they determine safety. That's the, hey, it won't kill you thing that you mentioned. Phase 3, where the drugs are right now for COVID, that's to prove effectiveness. And there's actually a particular statistical standard that's in place. And right now it's basically 50% effective, which is a low bar. But in comparison to the fact that we don't have any approved vaccines at all for COVID, the consensus is that's good enough to get started. So, doing clinical trials, the data can be helpful with that as well. We will help organizations identify where every clinical trial has a protocol, and the protocol is I want patients of this particular characteristic that don't have that particular characteristic. They'll call those inclusions and exclusions. And we have organizations that will use our data to identify what pockets of the country to focus on, because we get to see,
Right.
what patients meet their protocol. So we try to make that process more efficient. And then once the drug is approved, now, you can begin to do the observational research to add, granularity and color to the approved drug.
There's so much, and as Paul said, I don't want to make this political either way, but there's so much demagoguery flying around regarding the COVID-19. My question is the government using your data and accessing? People say, masks work, masks don't work. 85% of people have COVID, wore a mask. Indoors versus outdoors. Some groups are more have worse outcomes than other groups. I mean, all of this would seem to be resolvable through data. So again, my question is our government and anybody out there making these claims actually doing it from a foundation in data? Are they working with you to actually see what the data is telling, or are they just popping off?
Most of the work that we do is with academic medical centers, and a number of them are affiliated with government institutions, so they'll get funding from the government. So yeah. We've tried to avoid the political fray. There's just no good outcome from that, because whatever we do, half the country is not going to like whatever we say, and that's just not productive. But you are right. Having data at your disposal, is where our attention ought to be. I mean, we believe in science, and what we want to do is work with, passionate, smart people in medical research who are committed to understanding this terrible disease and coming up with solutions that helps get our country beyond the pandemic. And I tell you, man, I see all the stuff that you do on the news, and it's really easy to get disheartened by the political rhetoric. But you talk to these people who've dedicated their whole lives to trying to make people healthier, and it is really inspiring and heartening that there are a lot of people that deeply care about using data, putting it to work in the right way to get this terrible pandemic behind us.
Let's talk about that. I'd love to hear more about that, because so much of it is bad news. Tell us more about what are you hearing? What are these wonderful people? What's going on there?
Well, let's see. So first of all, I think when people get COVID today, the protocols for care have much improved. So today in October versus March, you're much less likely to die.
That's good.
And part of that is the protocols, the procedures that doctors use are better. When if you think about early on, there was a great rush in this country to get ventilators, in hospitals, and the sad truth was if you got intubated on a ventilator, about 80% chance of you'd have an 80% chance of dying. So that would not be a great outcome. I think the country has stepped up, and private enterprise and public health have stepped up their ability to do testing. In the absence of a vaccine, that's the best thing that you can do. You can make sure that if people have symptoms, they get tested, and if they are infected, they quarantine. The social distancing, the mask. Chris, I know you mentioned in passing the evidence is overwhelming that masks are effective and are one of the most effective tools that we can do until we get a vaccine. So there's been a lot of progress on that. A lot of the work that we've done is looking at the impact of COVID on various conditions. So cancer, diabetes, we have one about to launch with expectant mothers. We have others that are looking at the intersection of the social crisis that exists in this country with the health crisis, looking at, are different populations being more severely impacted than others. So we have that work underway as well.
And I want to, because you and I talked about that a little bit with producer David, in the when we were talking about the show on Friday, but I want to make sure I understood what you said about ventilators, because I think that's fascinating. If I heard you correctly, what the data, because you're right, there was a frenzy in this country. We're gonna convert, Ford and GM are going to convert their production lines to creating ventilators.
Did they not, Chris? I don't think they were gonna. They did.
They did, right? And what you're saying, Tim, if I understood you correctly, was ventilators were not a good idea. Putting people on ventilators was the wrong thing to do in many cases. Is that what you said? I don't want to put words in your mouth.
You might be mixing causation with correlation here.
Okay.
The reality was, if the progression of COVID in your body was such that you needed to be on a ventilator, the odds were about 80% that you were going to die.
Right.
So we were, fixing leaks in the Titanic, right? Unfortunately, the patient was so far gone that it wasn't going to make that much of a difference for 80%. Now, there is a moral judgment about the other 20%, of course, who live, and maybe there are circumstances where there were 20% and they needed a ventilator and couldn't get it. But on balance, if you got COVID and you needed to get on mechanical ventilation, it was not a good prognosis for you.
So it's like we say down in Alabama, it's like shutting the barn door after the cows are out.
Like we say down in Alabama.
But no, in all seriousness, the idea being, the idea being, we've got to stop this before it gets to the point of the ventilator. We need protocols in place that stop that, because that's not a fix. It's data is showing that the outcomes are going to be bad. So we got to stop it before it gets
intervene
that far.
sooner, right?
Yeah, that's testing and that's social distancing, Chris. Those are the best things to do until we get a vaccine.
So one of the things I see, it's not, it is mask, but it's indoors versus outdoors, right? Folks I know here, in Tennessee, we've got those that are like, masks are stupid, I'm not wearing those. But then there's those that are like, no, I'll wear a mask. I want to keep other people healthy. But outside, it just goes up into the atmosphere. Is there a correlation between indoor and outdoor? What do we need to know about that?
Oh, for sure. If you are indoor with poor ventilation, that's a high, and there's lots of other people, that's a very dangerous situation. So, if you look at bars around the country. They are, definitely events that you have to be careful of. When the virus first came out, there was a lot of emphasis on, deep cleaning of places.
Yeah.
That's true. I mean, the virus will survive a little bit outside the human body, but as we began to understand the disease a bit better, it was about airborne transmission. And outside versus inside is a material difference. And you have the wind, and you have the weather that will affect that. So your risk of contracting COVID outside versus inside is definitely less. But in both cases, if you can wear a mask, you definitely should. And I know people want to draw their own opinions about it, but it's like, hey, I don't believe in gravity. If I don't believe in gravity, that doesn't mean that gravity doesn't exist.
Right.
And the same thing is true with masks. The research is overwhelming in support of their effectiveness.
Well, they're really, it's, and just, sorry, nerd, Paul, it's, wearing a mask, it doesn't as much protect you as protecting those around you. Now, I realize there's different types of masks, and there, the N95, which sort of breathes your air out, but then there's the kind that's more blocking. But it's really about protecting those around you, and then protecting you with their mask. I mean, is that the correct read?
That's right.
Okay.
That's right. I mean, if it's airborne transmission and you have COVID, God forbid, you should be social distancing anyway. But if you have it in, yes, indeed. But part of the nefarious part of COVID is you can have it and not know it.
Right.
So having the mask on when you're around other people, particularly people that you don't know who they've interacted with, is just a safe thing to do. And what I would just say to people watching here is just power through this, man. Yeah. I mean, we're gonna get through this, and the more that we take the actions to keep ourselves safe, those who we interact with safe, the better off we're going to be, and the sooner we're going to get this behind us.
Sure.
Which will be nice, particularly as the weather gets colder in the north. The less time outside, more time inside, and
right.
That's why a vaccine can't come too soon, because it'll be interesting to see the data. You have Midwest spikes up. Let me ask you something, Tim. I mean, does the data tell you why suddenly is there a spike in the Midwest? Illinois in particular, our state, can the data tell you anything, or is it is it less empirical and more, well, people are getting tired clearly and they're just not wearing masks as much, or they're going to bars? I mean, is there an answer in the data as to why the Midwest suddenly is spiking?
Yeah. And there's two other data sets that, if you marry it with ours, that will help to provide answers. One, there are other companies that do location data. Mm-hmm. So they have tracking data on your phone. So having the ability to, and that's a good proxy for whether or not people are social distancing. So right. You can look at various geographies and the degree to which they are social distancing and match it up with the COVID encounter data. The other dimension that we haven't done, but some of our researchers have, is they have looked at the rate of COVID encounters by government policy. You said you didn't want to get political. I don't want to do so either.
I do.
But I'll say
what you're going to say.
No, Paul, stop, Paul.
To the degree that a governor or a mayor treats the disease as something to be contained, generally the rate of encounters is a little lower. Now that has to be normalized by population, right? Because the more people that are around, the more exposed you are. And others that want to emphasize, hey, we got to be open, this is America, baby, they are the ones that have a little bit more exposure. And because what happens as a knock-on effect is that, people sadly don't think it is as serious as it really is.
Yep.
And therefore they don't wear masks, they don't social distance, and then there's unfortunate consequences to that.
But one of the things that would argue, I'll take the opposite tack here a little bit, is because, again, on the surface, what you said seems perfectly logical. But Illinois' governor, like him or not, is one of the toughest governors in the country when it comes to lockdowns and opening back up. He was one of the last to open up, and he opened up very slowly. And so, if you wanted to rank governors on their strictness around this, he ranked near the top. And yet Illinois exploded again, and the state is rolling locking back down. It's only a question of time till Lake County, where I live, is locked down again. So, is there an answer for that? Because clearly, clearly it's not that the rules weren't strict enough.
I could go look up the data, and it would unfortunately be on the computer where I'm looking at you right now. But I am almost positive that Illinois is in the top half of performance in relation to COVID. So it is a fair point to say that there is an uptick, because that is true. But when you look at per capita, when you look at positivity rates, when you look at inpatient, Illinois is in the top half, at least the top half of performing states. So you are right. There is an uptick, but if we were going to use that as our criteria, I think there would probably be pretty close to 50 states that are having an uptick. It's somewhere in the 40s.
Yeah,
right now.
40.
Well, and I could have answered, in some ways, I potentially answered my own question as I think back, is that part of the reason, I mean, his strict reaction is based on how his reaction has been all along. And so it just feels like Illinois is maybe doing worse than their bordering states, but that's only because the governor took knee jerk, and I don't mean knee jerk positively or negatively. He had a plan, and if you went over a certain amount, we're locking down again. And so,
well, I think Chris, there's a fatigue to it as well.
Oh, there absolutely is.
You know what I mean? Where you're like, I've been on lockdown forever. I'm done with this. My life needs to continue on. I'm getting together with grandma this weekend. We're going to do scrapbooking together because I don't want her to miss out on grandkids or whatever that is, right? I mean, so although we can say, oh, we're safe, fatigue, blah, I'm going to the bar.
Yeah. That's why I say just power through. I mean, we have drugs that are in stage 3 of the clinical trials. Odds are they're going to get approved, if only under emergency use authorization. And I'll leave it to others to critique how well or not the federal government has performed here. But clearly, one of the things they have done right is to pre-buy these vaccines, depending on contingent on approvals. And when they are approved, most reasonable people will say that anyone who wants one of those vaccines will have one probably by March or April. So I know that seems like a long time.
Yeah,
but
not in COVID times. March or April seems like tomorrow.
Yeah, so that's why I just put that out there. I think you're onto something, that people are tired. They want to go back to life as quote unquote normal, and I'm there. I miss live music, I miss live sports, but we gotta power through it.
Well, I have a friend. It's funny. He's a police officer, running buddy. And we got together maybe 2 weeks ago on a run, right? And I said, I started running again because of this. I wanted to be as in best health that I possibly could, so that when it does hit, it's not as severe. And he was like, me too. Tell me, where does exercise fit into the response of this? Because you would have access to that data as well. I mean, are we crazy in thinking, let's get healthy? Or is that just a good job, you got healthy?
Well, whether or not we have a pandemic, you should get healthy. I mean, a good portion of the conditions in, or the money that we spend on healthcare here in America is a result of poor health.
Right.
Yep.
Some people say it's 80%, and this is what they mean when they say that.
Tim, on poor health, do you mean poor health habits? In other words, people
like
who
the
aren't
fact
in
that I'll
shape,
eat 3 tubs of ice cream in one sitting. I mean, is that what you're getting at, Tim?
Yeah.
I mean, go ahead and teletype this one.
So you eat poorly, you don't exercise. Those are poor health habits that lead to poor health outcomes. And about 80% of our costs in America are a result of that: eating poorly, not exercising. So, and in particular, the running thing is a good one. Just remember the R in SARS is respiratory, right? So it attacks the respiratory system. So having a good, strong respiratory system, and the cardio workout that you get from running is that's good for the body.
Hit the hills is what you're saying.
I'm not a fan of the hills.
Or if you want to preserve your joints for old age, there's always that elliptical machine that get that same cardio.
Biking is fantastic. Elliptical is fantastic. Walking is fantastic.
Walking is fantastic.
All available.
Right. You don't have to run. I mean, I know Paul's a big runner. Tim's a big runner, but something to be said for the elliptical machine and Netflix.
Or even
elliptical machine, Netflix.
When it's 13 degrees outside, like no one wants to go outside.
Right.
Ellipticals are powerful. Stationary bikes, rowing machines. There's 1,000 things. It's gonna be a good thing.
Yeah. Find a way, man. Find a way.
Power through it.
Power through it.
So even before this pandemic hit, Tim, you had said, or you've said in the past, that the U.S. healthcare industry is in crisis. And again, this is pre-pandemic.
Right.
Yeah.
And I'm guessing a lot of that was based on poor use of the type of data that we've been talking about. So rather than have you expound on why you thought it was in a crisis then, I'd rather hear, do you think, we're looking for silver linings on this, on this whole epidemic. Do you think the healthcare industry has learned any lessons that will continue afterwards in regards to the collection of data and the use of that data?
Yeah, so I'll take kind of a circuitous route in answering your question. So we're on Email Geeks here, right? So how did we spend all of our how did we spend all our time talking about COVID? And I as Chris mentioned, he and I worked together at Axiom back in the day, and I've spent a good portion of my career in advertising, marketing land, and financial services. And during my time there, I was using data and technology to further advertising, so to help people sell another tube of toothpaste. And I was working with big banks, because in addition to another tube of toothpaste, you need another credit card.
Of course.
And I got thinking, I'm now at a certain point in my my career, it's like, isn't there more something more purposeful that we can do? And to your point, Chris, I mean, right now our country spends double any other country in healthcare costs per capita, any other developed country. And for that investment, we rank number 43 in the world in life expectancy. That kind of sucks. Yeah. So I looked at that and said, are there learnings that we could take from advertising and from financial services and apply them to healthcare? And that's why I came to Change Healthcare.
Yeah.
And so your question, is healthcare learning? Healthcare learns every day. The challenge that we have is that it is highly, highly fragmented, and the many of the things that they want to do, they're actually blocked in terms of having the necessary information to make those decisions about protocols, about outcomes, about effectiveness, about who the best doctors are, best hospitals are, as measured by cost or quality or outcomes. And, we've kind of stepped into that breach to be an entity that is independent. I mean, we're not owned by a hospital or any doctor or any health insurer. So there's no temptation for us to step on the scale. And all we're interested in doing is making this information available so that those who are as passionate as we are to help improve individual healthcare in this country, so to do research, to make sure treatments are safe, to improve outcomes, that they have the necessary data to do that. And then we want to help on the economics side of the equation. This fragmented system, entails, I don't know, $300-400 billion a year of administrative expense just in healthcare, which is about 10%-ish of the money that we spend. That needs to go down. And we also need to transition from a fee-for-service model into a value-based outcome model. And, the payers are, moving in that direction. And if you're going to do that, if you're going to say, hey, I'm not going to charge you X amount of dollars for this maternity stay, it's going to be X, it is going to be X amount of dollars for a maternity stay, independent of the actual procedures that are performed. More organizations need to do that. More organizations need to be held accountable to the outcome, and the only way that you can do that is with data. And we're working hard to try to make that easier for organizations to do.
That sounds great. That would be when you think about it, Tim, private industry tends to drive costs in as a survival mode. Private industry tends to drive costs out of the equation, and healthcare stubbornly, as you pointed out, drives these administrative costs. I mean, in almost every other industry on the planet, there'd be a board turnover if there was overhead was eating up all these dollars. And I guess part of that is the regulation. I guess part of that's the fragmentation, and I think a big part of it is, as you said, I mean, it's not outcome based. It's and I love that thought. I hadn't heard sort of that. And I'm a healthcare geek in terms of how we can make it better and drive costs out. And obviously I lean on competition heavily, but which would also be the outcome based. It's what's the maternity cost and not what's each little step that goes into it, because you're going to be incented to not have a lot of these additional steps that aren't necessarily required, tests that aren't necessarily required, and make sure the outcome goes as smoothly as possible, because your margins are going to be dramatically affected by that. And I think that makes a ton of sense.
Right.
One other, I see we're getting close to our lightning round, which is our favorite, which I'll explain in a second, Tim. But there's one other thing I wanted to ask you, because the data I know will show this, and which is another negative outcome of COVID that we've all been told happened. And I've got anecdotal evidence. A friend of mine just yesterday, I shouldn't be laughing. I got an email from him saying, what's been going on in his life, and his shingles vaccination had been scheduled for March, and COVID hit, and his doctor wasn't doing routine stuff, put it off till July, and lo and behold, he got shingles between those times. So
that is hilarious, Chris.
Right. You knew my buddy would say that, but I won't say his name. But much more serious diseases. Again, there's anecdotal stories that we hear. Cancer diagnoses were delayed and were worse when they finally got caught, and that by locking down hospitals, saying pandemic only, there was a boomerang effect, not boomerang effect, but
knock-on effect.
That other diseases, people got worse because they were delayed. Does the data support that? Because that would seem to be a black and white data issue.
For sure. There were the visits to hospitals and doctors went way down. And part of the challenge that the researchers have, those that we are dealing with, is to understand, well, what is that likely to mean over its life? So cancer is obviously a very serious diagnosis. And if you're scared, to go into the doctor, or if your doctor won't see you because they're scared, that is not likely to have a positive impact on your prognosis.
Right.
And it's going to vary by disease state. It's going to vary by the severity of the condition. It's going to vary by different population cohorts, men versus women, different ethnicities, and the reality is we don't precisely know the answer to your question because many of these things have long-term impacts.
Yep.
And I know it seems like forever, but it's 6 months now into the lockdown, and many of these impacts are going to be much longer than that. But we do have researchers that are studying that.
Yeah, you're right. It's so funny. You're right. We're only 6 months into it, and oftentimes there's a long tail on these mortality rates. So
Yeah.
it's just an example of we all feel like it's been going on forever.
And I think we can universally agree this thing sucks.
Yes. To put it in medical terms, put it in clinical terms, it sucks.
Well, let's do the lightning round, Chris.
Well, this has been great, Tim, and great information. I think down the road we want to bring you back because I think there'll be more data to talk about. Sometime next year, hopefully, if this hasn't been an appalling experience for you, we can get you back and talk more about what's been learned. But again, I think fascinating stuff. Too often, as we've all sort of alluded to, discussions about the coronavirus break down into my way or your way, or this person did that wrong. And what I love was we've had a sober discussion about facts. And one of my favorite Tim Souther lines, because you had your own, I had mine, where facts are your friends, and you demonstrated again today. Facts are all of our friends, because when we move away from facts, it becomes emotional, opinionated, and those discussions are not productive. So
and the thing to remember, Chris, when you're talking about healthcare, there's a lot that we don't know about this disease. So it won't be unusual for medical professionals to have a different opinion about the facts. And one of the key things that exists in medicine that doesn't exist in other industries is when you put your facts out there in peer-reviewed research, all the best minds in America are taking their best shots at it. So they could say, hey, Dr. Marriott, that's the best thing, and here's my supporting evidence. I agree with you. Or Dr. Souther, that's the dumbest thing I've ever heard. Here's why your data is wrong. And this spirited debate about what facts really are, that is really, really encouraging to see that. So it isn't like the political thing at all where you can invent your own reality. This is like real data with, the smartest medical minds in America who are wading into it deep, and it is super, super heartening.
Great. Okay, good. All right, so today's theme, lightning round, Tim, is I say one word and you say the first thing that comes to mind. It could be a word or a phrase, but it's got to be immediately. That's hence the lightning. And Paul and I will subtly, potentially mock one or more of your answers. So maybe gently.
That's your strong suit, subtlety.
Exactly. Well, to be honest, this lightning round is morphed where early on, I mean, if you've been on one of our early episodes, I really didn't have an agenda, and I didn't in my mind say, here's what he or she better say. We've morphed into now, for every single one, I've got here's what she or he better say.
Yeah, all right.
Okay, so Chicago Landmark Edition of the lightning round. Paul, and I think we've lost your sound. We definitely want your sound for the. Well, while Paul fiddles with that, we'll launch into the lightning round.
Is that better?
Yeah, because we can hear you.
I can hear
so yes, it's better. All right, first one, Comiskey.
Socks.
Good enough.
Okay.
Well,
We would also have accepted Blackjack McDowell.
what a best pitching name.
Winning ugly.
I'll come back to Comiskey because there was a Chris Marriott completely approved answer to that. But I'll take Sox.
Second best baseball stadium in Chicago. Is that what you're looking for?
No, what I was looking for was what any true Sox fan refers to the stadium the White Sox plays in, regardless of its current name. Guaranteed rate now, the cell.
Yeah.
It's Comiskey. Okay, number 2, Sears.
Not the Willis Tower.
Yes. Oh, there we go. Again, another name that true Chicagoans, bravo Tim, will not refer to the tower currently called Willits as anything other than the Sears Tower. So again, landmark edition, Paul. These are true Chicago people. Third one, less of agenda here. Shed.
Aquarium.
Boom. I got nothing on that one. Just wanted to make sure that you weren't thinking of backyard sheds.
Tool shed was next. Yes.
Number 4, magnificent.
Mile.
Boom.
Marriott, Magnificent Mile Marriott.
Yes, exactly. On there. And we love to educate our fans. And so here's a bit of education there. Many people, particularly those from out of town, wrongly refer to it as the Miracle Mile. That's not true. In Chicago, it's the Magnificent Mile. So when you come to town and you ask for the Miracle Mile and somebody gives you one of these, you'll know now why. You look like an out-of-town rube.
Super helpful, Chris. That's actually, we're all better because of that question.
You know, as Tim said pre-recording, I'm a giver. I want to give.
Okay, what's next?
Help. It's a natural instinct. Final, last one. Wrigley.
Field. Home of the most recent World Series champion from Chicago.
I will give you that. I will give you that. I would have preferred an answer along the lines of home of the second best Chicago baseball team. Because as you can tell at home, I'm a Sox fan. Tim's a Cubs fan. Though Tim actually lives where there are probably more White Sox fans, and I live where there's more Cubs fans. Chicago, our tribes are very, very mixed, and so you can never be sure the person next to you who their affiliation is. I will add that there is a saying in Chicago that there are White Sox. I'm sorry, got it wrong. There are baseball fans and there are Cubs fans. Think about that. Okay, you guys got that. So anyway, Tim, this has been a great conversation. I think tons of great stuff that people don't hear because there's all this clamor surrounding the pandemic and having a good, thorough understanding of the data being collected and how that's being used.
Right.
Again, gives everyone a feeling that, despite everything happening up here, there are men and women, as you said, dedicated medical professionals, dedicated data scientists, dedicated companies like your company aggregating this that are doing the hard work day in and day out, not getting the spotlight shined on them. But at the end of the day, it's the work that you guys are doing that is hopefully going to bring this to a positive outcome, both, positive outcomes for people who catch it in the interim and positive outcome for vaccines and, sooner rather than later. And so we thank you for what you're doing and leading your company's efforts. And we thank you for being on today.
Power through.
Yeah, I was just going to say that. Wear a mask, power through. Smartest minds in America are working to help get this behind us. Paul and Chris, thanks so much for having me this morning. Really, really enjoyed it. And I look forward to baseball again next year. I think both our teams are going to be really good.
They are going to be really good. So hopefully we'll be able to go see them in person. So thanks, Tim. We appreciate your time and have a great rest of your week.
Yeah.
All right. Cheers. Have a good one, guys. Stay healthy.
Right.
Welcome back.
Welcome back to the post-show shenanigans, as evidenced by fan favorite producer Dave, with his mustache, which we never know if it's real or not until he shows us. He could have grown it in the last week. So, and with, is that a chip? No, that's not a chip. It's a groundhog.
I think so. I didn't even notice that thing. It's right behind me, and it must have snuck up on me.
It's clearly chewing very quietly. How about that episode, Paul? How about
that episode? I mean, spectacular, absolutely great. It's COVID, something that everyone's, we've gone to high school with, is now an expert on, and a scientist, and sharing all of their memes that we're all so much better for.
I mean, the Facebooks is such a font of reliable information on COVID, but we like to balance that with actual hearing from an actual data scientist in many ways, whose company is at the forefront of actually reporting on these things.
So many, I know what I believe, just like what you believe, and David, what you believe. At the same time, when you're barraged with so many sort of counter argument messages, you get to that point where you're like, well, maybe I'm believing the wrong thing. Like, even though what I mean? It's this vortex of misinformation that's absolutely miserable. To have someone who can say, no, like, we've got a gajillion million billion messages per day from care messages. Like, this is what we're doing. This is what we know. It's like, okay, cool.
No. We'll have to have Tim back at a later date, particularly around the time of a vaccine, and hear what the data tells us then. For those of you with sharp eyes, you may notice as well that I'm back in Illinois, back in my cockpit in the main studio, main Email Geeks at Home Illinois studio. Am I happy about being back in Illinois? I can't say I'm happy. It's cold. It snowed yesterday. I left 85 degrees. I mean, if you remember the sort of joie de vivre that I had when I was sitting on my back porch.
You were a different person.
I was a different person. Yeah. I mean, I'm even wearing a dark shirt. I mean, I'm somber. It's
feedback we've gotten from watchers and listeners was overwhelming. The story was, we need Chris back in Alabama because you're a different person there.
Well, and we'll be back in 3 weeks, God willing, and I'll be happy again, and I'll try to just soldier on, or as Tim said, power through. I'm going to power through 3 weeks of cold, getting colder, dying trees, the world dying around me. No dark. Flowers.
I'd vote. Let's transition from the dark here, Chris, over to David Inman, producer David. Would you please tell us about the type of corn your little rodent guy is he? Oh, he dropped it. What kind of corn is that?
Well, I'm not much of a corn expert beyond just my small scope. So I think the reason that you're asking is because I've taken up corn growing earlier this year, and so I know that there are at least 2 different variants of corn.
A corn farmer, if you will. I mean, that's how I refer to you to my friends. I'm like, gotta call my corn farmer friend David Inman. Producer David.
Yeah, well, actually, okay. I said there were 2 types of corn. I can now think of 3. There's standard yellow,
right? Standard corn, right?
Pop, obviously,
right? Which is also
popcorn, right?
Yeah.
Very popular corn. Hence the name Pop, potentially.
Right. I've seen it at movie theaters.
Yeah, that's the one. And then the 3rd variant, of course, is gym corn, which is a bit of a luxury item.
Yes.
The most luxurious of the corns.
Right.
What was that? Gym corn or gin corn?
Gym corn, GEM. And you've probably seen it before in cornucopias.
Yep.
In Thanksgiving table decorations.
Well, here's my question, Mr. Corn Expert. And I have there was a guy, farmer. I know a gentleman farmer by the name of Ben Ross, and I call him a gentleman farmer because he got a farmer MBA at Cornell. I used to work with him. Ben, if you're listening, shout out to you.
That's all you could hear was Cornell, producer David. That's all you could hear. And that whole thing, you were like, Cornell, what?
Well, that's where they train gentleman farmers. Who get an eye for good bottom land. And anyway, since I can't ask him, he's not here at the moment. How do they make those little colored corn kernels in those corn that you hang outside your house? I mean, most corn is yellow, and yet when these certain types of corn, and I'm not sure if there's if you know, the traditional name for them might be frowned upon in these days. So I will refer to, I guess, as Native American corn. But do they paint those? Do they?
How do they do it, Farmer
How
David?
do they get those brightly colored kernels?
Producer Farmer David.
That's a good
Yeah.
question. And I'm probably the leading researcher in this field. That the corn that you're referring to, Chris, is what I was referring to as gym corn. It's the corn that takes on variations in color. It's sort of a pearlescent sheen. It's a variety of corn, and actually I have no idea where it comes from or what it is. I know it's not really edible, but it exists, and I know nothing beyond.
And he's growing it.
Because they
And he's
inject-
growing it, Chris.
Do they inject dye into it? Is that
No,
why
no. This is what he's making, Jim Corn. When we first started talking about this was back January, February of last year, pre-COVID. This is when producer David shared with me his desire to become a corn farmer.
And so gem corn,
Jim Corn.
Yeah.
Jim corn. Well, that's Southern, that Chattanooga. Yeah, I mean, most of America would pronounce GEM, gem, but
G-I-M, Jim Corn.
he said GEM.
No,
David, how did you spell
I did spell it GEM. Is there a fourth type of corn that I don't know about?
oh, so you Jim G. Oh, it's an animated GIF is essentially what you're talking about. Jim Corn,
it? A GIF?
a GIF,
A GIF.
a GIF.
A GIF. This is going downhill fast. Well, I mean, so do you have any examples of your gym corn to share with us? I mean, did your crop come in? Was it a swarm of locusts that took ate your crop?
They might as well have, Chris. I'm gonna have to try again next year. What I ended up doing was underestimating the size of the container that I would need to grow a gym corn crop, and so I ended up with just like half stalks and no gyms to my name.
Oh my God. So,
But you know what? You forgot. You did forget. All right. So you said there's corn,
popcorn.
there's popcorn, there's gym corn. What about candy corn?
That's a thing too.
Yeah.
Why don't you try planting some of those and see what springs up?
I know. Well, my question is, are they grown as candy corn produced the same way of regular corn, or is there another process that
I would assume it has to be. Corn is corn, I think.
I would think?
Uh,
You know what, David? We're going to give you one of these assignments that you ignore, that you completely ignore, but we'd like you to come back next week with a presentation on various corn growing techniques.
Yes.
And tips and tricks on how to prepare corn even for a Thanksgiving dinner. Now, I even bring up Thanksgiving because I love this time of year. It's when you start getting your honey baked ham
Oh yeah, Thanksgiving honey.
coupons
Right.
in the mail, and this is a particular coupon: $5 off a 50 purchase or $8 off bone-in half ham. I mean, that's a major coupon award.
That's a big deal. $5 off.
Yeah, that's a big deal. So Honey Baked Ham, it'd be nice to get somebody from Honey Baked Ham on the show at some point, because frankly, there aren't too many things more delicious on the planet than Honey Baked Ham for a holiday meal.
Yeah. So, if, Honey Baked Ham, if you're listening, watching, we'd like to have you on the show.
We'd like to have you on the show, and not because we hope that we can score more major coupons, but
Right. I think an unboxing of a honey baked ham might be an interesting opportunity for them to get their ham in front of more people.
Well, and I'll tell you this: in Fairhope, Alabama, there's a Honey Baked Ham restaurant. I mean, the Honey Baked Ham company, they have a restaurant, so that's very exciting. I haven't been there yet.
Well,
My wife has very strict. Ham is not, according to my wife's rules of Thanksgiving. Ham is not a Thanksgiving dish. So I will have to, I'm lobbying for Thanksgiving Eve potentially being a ham.
I mean, that's what we
opportunity.
have every year is we'll do honey baked hams for Thanksgiving dinner. I've never heard of anything else. What do you guys use for Thanksgiving, Chris?
We use turkeys for Thanksgiving.
Never heard of that.
So one time a year, most people. Well, producer David, break this tie: honey baked ham or turkey for Thanksgiving dinner.
We like to mix it up. Honestly, I think ham is superior, but turkey is the default option.
Well, you heard it here.
Heard it here. All right.
You heard it. I have one final question before, since we're dragging this to death, and that is, that mustache actually looks like it might be real this week. Is that a real? Is it actually now a real mustache?
I guess we'll never know.
Oh, wow! It's getting better though. The technology is getting better.
Right.
Fun and games.
Well, with that said, I think we put another show to bed.
Yep.
If you're still watching, we're grateful. Like, subscribe, share this with your friends. Earlier when I was saying we were trending on the YouTubes and the podcast, I wasn't kidding. We are seeing lots of interest and value. People are watching it. People are sharing it, talking about it. I think specifically this episode may be super helpful for folks that are scared of COVID, for folks that are tired of being home and feeling like there's never going to be a way out. This is a great one to share with friends.
Yeah, exactly. This is definitely one. If you haven't shared one in the past, share this with some friends of yours. Again, because I think Paul's right. It does. It gives you real facts. It gives you real details, and tells you how you should be feeling about things. And that's all good. So thanks for bringing us into your car, your home, your tanning booth, wherever you're enjoying this. Thank you for sharing time with us, and we'll see you again next week.
Thank you. Thanks, y'all. Be well.
See ya.